A comprehensive assessment generates a massive amount of data. The diagnostic phase organizes that raw information into a coherent clinical picture. The formal diagnosis of mental and substance use disorders is strictly governed by credentials. It is reserved for qualified professionals acting within their licensed scope. A chemical dependency counselor is responsible for understanding the diagnostic criteria, gathering the supporting information, and accurately relating the substance use problem to any coexisting conditions. To do this effectively, the counselor must document their findings precisely, drafting a clear diagnostic summary. The goal of this entire phase is to achieve an integrated understanding of the client's strengths, problems, and needs, rather than simply applying a label. This graphic represents the DSM-5 architecture for defining a substance use disorder. It organizes 11 specific behavioral criteria into 4 conceptual clusters. The first cluster is impaired control. This includes using more of a substance than intended, unsuccessful efforts to cut down, spending significant time obtaining or recovering from the substance, and experiencing cravings. The second cluster covers social impairment. This involves failing to fulfill major role obligations and giving up important activities despite recurring interpersonal problems caused by use. The third cluster identifies risky use. This is defined by recurrent use in physically hazardous situations or continued use despite the client knowing it worsens a physical or psychological problem. The final cluster isolates the pharmacological criteria, building a tolerance to the substance and experiencing withdrawal when use stops. Grouping these specific behaviors into 4 distinct categories gives the entire treatment team a standardized clinical language. This scale shows how severity is quantified. The severity of a substance use disorder is established entirely by an objective mathematical count of how many criteria are met. Meeting 2 to 3 of the 11 criteria indicates a mild disorder. 4 to 5 criteria establish a moderate disorder. 6 or more met criteria confirm a severe disorder. Counselors track these specific counts to connect the clinical picture directly to a justified, appropriate level of care. Trauma is highly prevalent among individuals with substance use disorders. Screening for it must be a routine part of every assessment, rather than reserved for clients who actively volunteer a history. When trauma goes unrecognized and unaddressed, clients face poor engagement, a higher risk of premature dropout, increased relapse rates, and misdiagnosis. Screening must evaluate depressive symptoms, sleep disturbances, co-occurring substance use, coping styles, and any risks for self-harm, violence, or suicide. A positive trauma screen requires an immediate shift in treatment approach. It dictates a fuller trauma assessment and demands trauma-informed care across all subsequent sessions. The act of asking about trauma can itself cause severe emotional distress for the client. The counselor must balance the clinical need for information against the client's immediate safety and readiness. Clients should never be pushed to disclose more than they are prepared to share. This diagram illustrates a critical statistical baseline in addiction treatment. Roughly half of all people with a substance use disorder also experience a co-occurring mental health disorder. This high prevalence introduces a major diagnostic complication. Active intoxication and withdrawal closely mimic psychiatric symptoms, presenting as severe anxiety, mania, or even psychosis. Diagnosing prematurely during periods of acute use risks both severe overdiagnosis and underdiagnosis of actual mental health conditions. The clinical picture must be observed over time, ideally during abstinence, to separate substance-induced conditions that resolve when use stops from independent disorders that persist and require ongoing treatment. A second major caution involves client resistance. Behaviors that appear to be denial, manipulation, or a lack of motivation are frequently active clinical symptoms. The flat affect of depression can look like poor motivation. The hypervigilance and avoidance of post-traumatic stress can present as a hostile or guarded attitude. The counselor screens for these co-occurring conditions, refers the client for psychiatric diagnosis and medication evaluation, and integrates mental health-aware strategies into daily counseling without overstepping their diagnostic scope. Recognizing these patterns prevents the counselor from mislabeling the client. It reframes difficult behavior as something to be systematically understood rather than confronted. Comprehensive assessments frequently uncover histories or immediate concerns regarding child abuse and neglect. Suspected current child abuse or neglect triggers mandated reporting obligations. These laws override client confidentiality and constitute a non-negotiable professional responsibility. The counselor handles these disclosures objectively and without shaming, following required jurisdictional procedures while continuing to support the client through the process. Beyond legal mandates, the diagnostic phase clarifies strict clinical limits. Active psychosis, significant suicide risk, severe medical conditions, or any diagnosis outside the addiction counselor's scope require immediate external referral. Identifying these triggers and actively connecting the client to specialized services is a core clinical competency, not a failure of the treatment program. Ethical practice requires absolute clarity on what the program can safely manage and what necessitates outside expertise. All gathered data culminates in the diagnostic summary, a concise, logically structured narrative that unifies the assessment into a single clinical picture. This document states the substance use severity, identifies any coexisting medical or psychosocial conditions, notes the client's available strengths, and establishes the primary priorities for treatment. A competent summary strictly avoids jargon. It distinguishes direct observation from interpretation and makes no claims unsupported by the raw data. It also explicitly names any conditions that require the external referrals or medication evaluations identified earlier. A vague or disorganized summary yields a vague treatment plan. A precise, well-executed diagnostic summary bridges the gap between assessment and action, translating a complex client history into focused, individualized care.